Ladies and gentlemen, thank you for your patience in holding. We now have your presenters in conference. Please be aware that each of your lines is in a listen-only mode. At any time during today's presentation, you may submit your questions electronically by typing them in the chat window located to the right of your slideshow. You may also download a copy of today's presentation by using the Files window located directly underneath the presentation. It is now my pleasure to introduce today's first presenter, Mr. Chris Hund.
Thanks, David. Hi, everybody. This is Chris Hund, Director for Quality at the American Hospital Association. Welcome to the first monthly webinar for the AHA Team Training Program. This is on demystifying high reliability organizations with TeamSTEPPS. And thank you very much for joining. Like I said, this is the first monthly webinar for the AHA Team Training Program. With the conclusion of the funding for TeamSTEPPS at the national level for the in-person program, the AHA realized that this is something that there's quite a need for still, and something that's very important that this movement continues in the field, not only here in the States, but really around the world. So that's why we've launched the AHA Team Training Program. You'll notice that a lot of things are going to be the same, especially as we get going. There'll be courses that we're offering and monthly webinars and our national conference. But you'll also notice that we're going to try to bring quite a few innovations to bear over the course of the coming months and years. So thank you for joining us on this journey, and this is really the first step right now. So welcome. Just some rules of engagement for this presentation. So you could be listening here to the audio in two different ways. If you're listening through your phone right now, you're going to want to go mute your computer speakers. You can do that by, if you look at the top of your screen, there is a green speaker button. If you push that, you could take that down to white and that will mute it. You can also mute your computer speakers, of course, normally in the bottom right-hand corner of your screen. You can also listen to this through your computer too, if you want, if the phone's not a viable option. We're going to do Q&A at the end of the presentation. And as David just said, we'd love for you to chat your questions in the chat box, which is on the right-hand side of your screen. And what we'll do is we'll gather your questions up and then put them in a good order and try to have a very coherent Q&A at the end of the presentation. So please feel free to chat things in over there. We also, as David said, there's the file to download this presentation is the bottom left-hand corner where it says Files. And right next to it, it says Web Links, and that's where there's just a couple of helpful links for you to use to see about the program. So like I said, there's some upcoming events. We already have next month's webinar set up, November's webinar. It's Integrating TeamSTEPPS in a Simulation and Team Debriefing. It should be a lot of fun. We've got some great presenters for that. And then we also will have our first master training course of the program will be here in Chicago on December 14th and 15th at the AHA offices, which are in downtown Chicago. And registration will be opening for that very soon. So keep an eye on your email if you've signed up for the team training alerts, or keep an eye on the AHA team training website. Also like to announce our save the date for the Team Training National Conference. So like we've been doing for the past 6 years, we're going to have a conference that focuses in on TeamSTEPPS and other elements of teamwork and team training. We are going to be in sunny San Diego this year. Beautiful hotel location right on the harbor, so we really hope you could join us for this. It is going to be June 20th through 22nd. There is going to be some potential pre-conference sessions on June 19th and 20th. So just getting the save the date out for you right now. There'll be a lot of information coming soon about submitting your proposals for presentation as well. So we hope you all join us there. As always, get in touch with us if you have any questions. You can hit us up at that email address, which is teamtraining@aha.org, or the phone number, which you see listed there. Feel free to get in touch with us, and we'll get back to you as soon as we can with any answers to questions you have about the program, but also if you have any questions in general about TeamSTEPPS and how you could be using TeamSTEPPS in your institution. All right, so now I'm going to be introducing today's speakers. One of them is very near and dear to my heart because it's me. Very looking forward to speaking to you today. Happy to be able to actually present on one of these webinars as opposed to just host it. But I'd also like to introduce my co-presenter, Marcia Cooke. Marcia, would you like to say a few words about yourself?
Oh, absolutely. Thanks, Chris. I'm excited to be on this webinar. I've had the opportunity to work with Chris and his team in a variety of ways on implementation of TeamSTEPPS. As you can see by my title, I'm an assistant professor of nursing at a school in northern Illinois. And my background with TeamSTEPPS, I've really been able to use the tools both in practice as well as in some of the national quality improvement work that I've worked on, and now I am integrating it into the academic environment. So great to be on this call to share some of my learnings with you all and to hear from you. Thanks, Chris.
Thanks, Marcia. Yeah, very happy to have you here with us today. We think that we're going to be able to hopefully give you some good background on both HROs and TeamSTEPPS. So, you know, we really understand that HROs are a very tough journey. And it's also something that's very much about culture change. It's something that takes a long time. So going into today, we don't want you to really think about this as us telling you exactly how to do an HRO program in your institution. What we want you to instead think about is how you can use some TeamSTEPPS tools that you're familiar with already to start moving the ball forward a little bit. How can you, kick that can down the road just a little bit as we go through this and kind of help you start understanding how you could tackle some of the big HRO principles. So that's what we're going to do here. We don't want you to think about this as another initiative. This is really just how can these ideas start percolating and helping you move things forward. So we're going to talk about things clinically. We're going to talk about things non-clinically. And I'm going to also share just some kind of funny anecdotes about my family because I feel that, everybody on this call is coming from somewhere different and has a different profession, but everybody on this call can relate to being in a family. At some point in your life, you were, either had kids or you were a kid yourself or you have siblings or whatnot. So hopefully some of these stories can kind of illustrate some of these points. So we're going to really go at 3 questions today. We're going to talk about what a high reliability organization is and why it's important. With this, like I said, we're going to keep things very high level. We just want to have a shared mental model. Make sure that we're all on the same page. We're then going to talk about some practical ways that we could support it. And then we're going to end up with why it's important really to think about owning this as opposed to just asking people to buy in. So a little bit at the end on how you can try to support implementing these tools culturally. We'll hit that up. And then at the end of that, we'll have some time for some questions. So that's what we're going to do today. Okay. So what are HROs and why are they important? So that's what we're going to jump right into today. HROs, we all know from the AHRQ HRO guide that the most basic way of describing this are HROs are organizations that have processes and systems in place that are exceptionally consistent in accomplishing their goals and avoiding potentially catastrophic errors. So in other words, what we're talking about here are things like nuclear power, the military, airlines, one of my favorites, NASA. These are the types of organizations we're talking about when we think about a high reliability organization.
And Chris, it's interesting. So when you think about those industries, many of them embrace the HRO concepts because they had those past catastrophic failures, airplane crashes, nuclear reactor meltdowns, among others. So really responding to the signals that led to those disasters was essential, as was also responding to signals that could lead to additional catastrophes, also known affectionately as near misses. It's really hard to embrace those near misses, but, we need to think of it as a gift, the opportunity to prevent further errors. A near miss can be a wrong medication being placed in a patient's drawer in a medication dispensing system, or it can be a miscommunication about a patient's allergy. And while these two instances may have been caught before a patient was harmed, the next one may have more dire consequences. So thinking of healthcare as a complex environment, as I'm sure we can all attest, we need to intentionally integrate some of these practices and tools into the workflow and continue to develop that capacity in the members of our team. It's really essential.
Thanks, Marcia. Yeah, I had, non-clinically, I had the ability this past summer to go to NASA just as a tourist, just for a day to the Kennedy Space Center. And this was just going on normal tours with the tour guides, reading the informational plaques, even listening to the bus driver that drives you out to one of the launch pads. And everybody there was exemplifying what it meant to be an HRO. Didn't matter who they were. They all were stressing having a shared understanding of what the mission was. They were all very consistent in their use of language. So it didn't matter if it was the tour guide or the bus driver or something that was just written on a plaque. Everything was kind of coming at you in the same way. And so that really gave you that understanding that they all had that awareness of what was going on around them at all times. And they also all were very much talking about that ability to flag an error like you were just talking about. Just bringing that up over and over again, that anybody can sit there and say, there's an error, and stop the line. So very interesting. So TeamSTEPPS, as you all know, is something that's very similar. Culturally, it's all about improving teamwork and communication. And in improving that teamwork and communication, you really get to that place where you have that shared mission. You have a shared mental model, we would call it. You really understand what's going on. You really get that awareness of what's going on around you. You're increasing your ability to speak up when it's time to speak up, when something has gone wrong. And also, it really does lead to higher employee satisfaction. And why is that important? Well, it's very important when you start thinking about if everybody needs to be on the same page, you want to try to have the same actors as much as possible. TeamSTEPPS comes from the same background as what Marcia and I were just talking about, really growing out of crew resource management and coming up through the military and through those teams, the med teams in the military, those high-stress situations where something needed to be done to make the teams work better together, to make the teams communicate more efficiently. And then over time, it transitioned into what TeamSTEPPS is today over the last decade. So there really are a lot of connections here, and that's why I think that this is a good way of thinking about things together. Just looking here at everybody's favorite slide where we've got the barriers, tools and strategies, and outcomes, when you look at the barriers, you see that this is what really stops us from being consistent in how we accomplish our goals. This is what, makes it difficult for us to avoid errors. So that's why when you look at using these tools from TeamSTEPPS and getting to those outcomes, of course, the goal is always patient safety, but a lot of these other outcomes really kind of tune in to those elements that make up a successful HRO. Okay, so now we're going to get into the nitty-gritty a little bit. We're going to talk about practical ways that you can support your HRO with TeamSTEPPS. We're going to go through each of the 5 main principles of what makes an HRO, and then after we talk about each, we're going to focus on a TeamSTEPPS tool or concept, or sometimes tools, to help highlight how that principle, how that value can really be hardwired into your workplace using this. So that's what we're going to get into here. Okay, number one, sensitivity to operations. This is really the first, and in my opinion, one of the most important of the 5 elements of HROs. We know that any system is always undergoing some sort of change. It doesn't matter if the system is in a normal office environment, in a healthcare setting, or even at your home. Systems are always changing, so it's very important to understand what's going on with that system. You really need to have constant situational awareness about what's going on, because that's how you understand what everybody is doing. It helps you really scan for anomalies, but it also is something that helps you understand what's going on with the boots on the ground people. That's what's very important here, is interacting with the people who do the work, the frontline staff. They're the ones that are going to be able to really tell you what everything is going on in your operation. You know, standardized language is really important here too, because that gets everybody on the same page. Understanding that standard work is really something that helps you all have that global view of operations. So a story here, personal story. All right, so my kids, Max and Emmy, they're 10 and 8. They really wanted to make money, and they came to us and said, we want to make money. And we said, all right, well, you got to have an allowance. What do you guys want to do? We offered them up that ownership of choosing what they wanted to do. And Emmy, my daughter, the 10-year-old, said, oh, we will set the table before dinner. And I went, sure, that's great. Go for it, guys. My wife, being much smarter than I am, and being really the leader of the team at home, went right to the frontline staff and said to them, guys, how are you going to set the table? And right away, oh, we're going to get the spoons out, we're going to get the forks and the plates and the knives, we're going to put it on the table. Get some napkins and glasses. And my wife, Casey, said, wait a second. How are you going to get the plates out? Because they're shorties. There's no way they're going to get up on to those cabinets. And right away, my son said, not a problem. I'll climb up on the countertop and grab the plates down. And immediately, of course, the warning bells go off because, you know, Max plays a lot of soccer. He's always in his cleats. And not only were we worried about him slipping and falling off the countertop and breaking his head open, but we were more worried about our new countertops getting scratched. So we said, all right, guys, let's talk about how you, as the frontline staff, can help make this work better. And they had a great idea right away. Let's put the plates in the lower cabinet. And so right there, us moving the plates into the lower cabinet made it so that they could easily set the table. We moved the pots to the upper cabinet because my wife and I are the ones who do the cooking, so we can reach them easily. And we avoided a potential disaster. We stopped a potential problem from happening just by interacting with our frontline staff and learning about how they do the work. So in a very simplified way, that's what sensitivity to operations is all about. So I said that it's really important to think about standardized language when you're talking about sensitivity to operations. And you all know SBAR. You all know what it means, that it's about situation, the background, what's the person's assessment, and what's the person's recommendation or request. That A and R, that is very important for sensitivity to operations, because you're asking somebody who is doing the work currently to give you an assessment of their work and then to also give you a recommendation about what should be done. So you can see right there, that's really tying in not only reaching out to frontline staff, but also having a standardized process to help your operations.
And I think, Chris, using SBAR, really goes beyond the clinical staff as well. It could be used in an office environment I personally just used this last week when I was communicating a student issue to the department chair. So it can be used in a variety of ways, again, with that sensitivity to operations.
Thanks, Marcia. Yeah, I think that's huge. It really helps in the non-clinical settings too, with emails as well. It's a great way to kind of stop people from having, what we like to call word vomit, when it just is all these ideas on a page. It's really a good way to, clearly and concisely communicate. All right, so we talked a lot with sensitivity to operations about situational awareness, and so it's worth a moment talking about the situation monitoring process that gets us to having a shared mental model. So when you think about this, you really are thinking here in that situation monitoring place about mindfulness, about really understanding what is going on with you by scanning for that, by seeing what it is that you are doing and what it is that others are doing. It's really monitoring what's happening. When you move on to the outcome of having that monitoring, you get to situation awareness. And this is obviously something that takes some time to get to, but this is where everybody, if they're all doing their best to monitor the situation, imagine if everybody understood what they themselves were doing and what everybody else on the team was doing. This is kind of creating, it's almost like a hive mind or a neural web in a way, but it's getting you to a place where everybody knows kind of what's going on. I want you to think about this. If everybody has gained that situational awareness, think about what it would be like in your system if the CFO and IT and clinical staff and the patient safety department and security, if everybody had a general idea of each other's roles and responsibilities and what the general mission was, that would really lead to a place where not only is everybody situationally aware, but they're also having the ability to be very sensitive to operations and knowing what everybody's doing. That really leads to that shared mental model. Now, of course, you need to constantly look back at yourself. You can't just think you get to a shared mental model like it's a Zen state and you're just, you're sitting there in the nirvana of shared mental modelness. You have to continually roll through this cycle and take the time to continually be mindful and looking at yourself. But this is really where you can kind of understand your whole enterprise just by doing this.
Yeah, and Chris, when you really think about it, sensitivity to operations, it's more than just administering medications or checking a patient's vital signs. But as you said, it really includes maintaining that awareness of the complexity of patient care, including issues that affect care such as distractions, staff fatigue, inadequate supplies, among others. This all results in a shared mental model. And I'm sure many of us have had the experience of working with a team that just clicked. Where we had that shared mental model and almost intuitively we just worked well together. When I was a nursing student, I had the opportunity to work as an emergency department tech, and I was really privileged to work with the kind of team that really fed off of each other, that really understood their role, their strengths of each other's, and how to communicate. And not just how to communicate with ourselves during an emergency, but how to communicate with people who supported our team. When we had a patient that needed emergency surgery, how did we work with the operating room? It was really a refreshing place to work and a fun place to go to every day.
Yeah, it sounds like it. That's definitely, I think, a good point, that a lot of what we're talking about here, in some way people are already attempting to do this and are already doing this. And so it's getting to that place of kind of tying all the pieces together. All right, so number 2, the second value or principle of HROs is preoccupation with failure. And that's when, the first time you tell people what HROs are and you say, oh, we're preoccupied with failure. Everybody's like, why are you so negative? What is going on? Well, that's not what this is all about. This is about an understanding that there is always going to be some sort of failure. There's always going to be a near failure or near miss. And it's looking for those things, making sure that you are kind of ready for them, having those contingency plans almost in place. And then when they do happen, whether it's an actual failure or an almost failure, you review them. You look for those opportunities to make the fix so that you're constantly trying to make this change. So it's really kind of always thinking about and focusing in on what's going on with the world around you and seeing where there's potential problems. If you're a parent, you are always preoccupied with failure. That is just what you do. You're always looking out for what could go wrong with your kids. My son, Max, 7, 8 tomorrow, he actually turns 8 tomorrow, comes up to me and says, Coco and I are going to go build a tree house in the forest. There's a forest behind my house or near my house, and Coco's the little girl that lives next door that wants to get married to Max. And so they are going out to the forest, he tells me. They're taking some lumber from the garage, and they're going to build a tree house. Okay, so what can go wrong here, right? So immediately as a parent, my mind is going to, you're going to impale yourself somehow on a nail, or you're going to smash your hand trying to hammer. You're going to put the wood together, but it's not going to be well connected. It's going to collapse on you and give you a, some sort of head injury. There's going to be some creepy person in the forest that's going to kidnap you. All of those things, all those potential failures are running through my mind. But I also, of course, want him to have a good childhood experience and have fun. And so what we did is I talked to him about the potential dangers. Hey, if you see somebody in the forest, somebody that you don't know, or somebody that's not a kid, get out of there right away. You and Coco run. Hey, let's not bring the lumber to the forest. Let's instead, I kind of showed him how you could take some twigs and put them together, and I gave him a little blanket to put over it so they could kind of make a lean-to, something a lot more safe. And so that was that opportunity to discuss what we could do a little bit differently when I saw those failures kind of approaching.
And Chris, you talk about being a parent and always being preoccupied with failure. Unfortunately, through our lives, we go through that with our parents as well. So, as a nursing professor, I'm always looking to instill in my students the need that they really need to be ever vigilant in caring for patients, always thinking about what could happen. And working in healthcare really hasn't helped me with my own family members when they're in the hospital, because I too take preoccupation with failure with me. So in 2008, when my mother was having a craniotomy, I thought about what could go wrong. And while we respected the neurosurgeon and had confidence in the operating room team, I couldn't help think about what could go wrong. The surgery seemed to be taking a long time, so I went and I found the operating room doors, and I waited for them to open. And I wanted to see if there was a commotion going on or any indication that there was something wrong. The staff saw me, and they just assured me that everything was going as planned, and since I was concerned, they would send someone out about every 30 minutes with an update. And I had a chance to reflect on that later and thought, wouldn't it be wonderful if everyone in healthcare, thought about their patients as if they were their own family, being ever vigilant and speaking up when something did not look right. So that was my challenge as I went back to my own institution.
Thanks for sharing that, Marcia. I'm glad that things turned out okay. So when we think about this, what's the perfect time to be preoccupied with failure? I think it's really in briefs, huddles, and debriefs. This is really a moment where you can, of course, not only bring up potential issues during the brief, when you're sharing that plan, where you're talking about roles and responsibilities, where you're talking about potential things that can go wrong. But if something does start going sideways, huddles are a great time to get together and say, hey, we've noticed that either something has gone wrong, and how are we going to address it, or something potentially could be about to go wrong. And then debriefs, that's the review period we're talking about. That's the place where we can really bring up what didn't go so well. What can we do to fix it next time? And if you bring that into your brief the next time and complete the cycle, you've created a nice little PDSA moment that can continually address these potential failures or failures that have occurred. Another place to be able to do this and kind of have that preoccupation of failure is to really encourage everybody to use closed loop communication. Having that moment where people can either kind of see through the call-outs and checkbacks what exactly is going on. So my example for this is always if you think about going to a place like Starbucks. And so if I go to Starbucks and I order a venti, low-fat, skim mocha, right? The barista is going to look at me, going to address me directly, and say, you've ordered a venti, low-fat, skim mocha. Right there, that is a closed-loop communication. I can check for errors. I could scan for any anomalies in what she said. Then that barista is going to turn to another barista, the one who's actually making the drink, and is going to say, venti, low-fat, skim mocha. That person repeats it back to the cashier barista. And I'm there as well. All of us are scanning and making sure nothing has gone wrong. If that one barista says back, yep, a grande skim mocha, I could say, no, that's not what I ordered. Anybody has that ability to speak up. So that's really, in my opinion, is a great way to also be preoccupied with failures by using this and constantly checking in with each other. Okay, number 3. The third one is deference to expertise. This is really asking you to listen. As simple as that sounds, it's really being open to respond to the expertise in the room, regardless of rank, regardless of how old they are, what their position is, what their title is. I think we all kind of inherently know this, that status doesn't make expertise, but it's very difficult in situations sometimes to do this. This is one of those things that you're like, of course I'm going to listen to the expert. But sometimes you don't. Sometimes you just feel like you want to plow forward. You're the person in charge. You're in charge of this situation, so I'm going to just move forward. My best example of this is really with my daughter. She is a huge fan of baking shows. She wants to be the next great British baker, even though she's not British, so I don't know how that's going to work for her. She is so into baking and doing all this. And so my son and I have soccer, and my daughter and I have baking. And so I say, let's put some time aside every weekend. We're going to get together and bake when we can. She loves it. And she said, okay, we are going to do a key lime pie. And normally, we're not looking at super complicated things. And I pulled up a recipe, and I was like, all right, we've got to make the actual pie crust. We have to make the filling. We have to make the meringue on top. This is looking very complicated. So I said, hey, honey, let's go to the store. We're going to get a pre-made pie crust. We're going to put that one. We're going to do the filling of the meringue. We're not going to worry about dough for the first time all today. She's fine with that. So we make our filling, and we're doing lime zest, and it's beautiful. And then we work on our meringue and do that and make it going. It's nice and stiff. And I pull out that pie crust, and I pour in the filling for her, and I say, okay, put the meringue on top, and she does that, and I'm having her make little peaks with a spoon, and it's beautiful. And I say, okay, we got to pop it in the oven for 5 minutes now. We don't want to overcook it and burn the meringue. And she looks at me and she says, Daddy, no, we have to cook the pie crust longer. It's not done. And I said, honey, it says in the book to put it in the oven for 5 minutes. We're going to put it in the oven for 5 minutes. She said, but that's not how pie crusts cook. I watched the show, and you put in pie weights, and you pre-bake the crust, and then you put the filling in, and I just blew right by her. I said, nope, we're putting it in the oven. We have to get this going. I put it in the oven. took it out 5 minutes later, beautiful meringue, nice brown tips to it, and entirely inedible because the pie crust was, of course, raw. I didn't defer to her expertise as somebody who knew a lot more than me about baking, and I blew right by her because I was pulling that rank. I was the dad. I knew what I was doing. We were moving forward. So you really need to have deference to those boots on the ground, to the people who are doing the work, if they are, in fact, the expert in something.
Chris, I love that story, and I've been in many of those same situations where I had to, stop and think, am I the expert here? Am I the one who has the most knowledge, who has the most to contribute? So, back to the example of my mom's surgery, I come from a family of healthcare providers. So I'm a nurse. My mom's a retired nurse. My sister's a nurse in a pediatric clinic. My brother-in-law is the director of surgical services at a hospital in Chicago, and another sister is an operating room tech. So when I was worried about my mom in the operating room, I deferred to the expertise of my sister, who's the operating room tech. While she didn't have the most education or experience in healthcare, she had the most experience with this particular situation. So she could help us understand what was happening in that room. So sometimes it's hard to do that, but it really benefits the entire group when you can, have those who have the most knowledge speak.
That's for sure. Thanks. Yeah. We really think about tools for deference to expertise, and I'd like to put forward that CUS is the greatest tool for this because it allows people, either clinically, to get to that escalation of I'm concerned, I'm uncomfortable, this is a safety issue, to the non-clinical of I'm concerned, I'm uncomfortable, this is a success issue. My daughter could have spoke up. Well, she did speak up, and I didn't pay attention, so culturally there's a problem there. But if we were using CUS, she could have said, this is a success issue. This pie is not going to be good. I mean, it could have been a safety issue, too. If we ate it, we might have gotten sick because it was raw dough, but it's one of those moments where somebody culturally has a tool that they can use to challenge somebody, and kind of by using the standardized language, by using the tool that's been embedded in your culture, hopefully will ring a bell for that person to say, I should listen, oh my gosh, that person's the expert, I should be listening to what their concerns are, what they have to say. Okay. Number 4, home stretch here, is resilience. Being resilient, there's a lot about this right now, a lot about reframing things, about thinking things differently. Resilience is definitely, of course, about what you do when you're bouncing back from a major situation, a major emergency, a death, something horrible that's happened, maybe a natural disaster, because we've been obviously seeing more and more of that in the news, some sort of horrible thing that's happened, a shooting, whatnot. But resilience is also about bouncing back to a normal state when you're dealing with a lot of small things. It's that death by 1,000 cuts type thing, right? It doesn't always have to be catastrophic. It can be a lot of small things that build up over time that could really take away the resilience of your team, and that's going to lead to more possibility for error. That's going to lead to less ability to be situationally aware and kind of sensitive to your operations. You need to keep your resilience up, and you need to kind of build systems to kind of detect it, to control what the problems are, and to be able to bounce back. Another thing that really leads to a lack of resilience is conflict. If there's a lot of little sniping conflict going on, a lot of issues that are maybe not in the open, but there's a general malaise that's kind of happened, that's going to lead to a lack of resilience too. In any family, that's just what happens when people even are sick, right? If people are sick in your house, all of a sudden the team's kind of falling apart. It's the person who normally does dinner isn't available. The person who does the soccer practice driving isn't available. Who's taking out the garbage? And God forbid if in our house, it's a full-on man cold for me, because then I'm down for longer than any human possibly should be for a cold. So we're sitting there and we need to learn how to build in those resilient systems to kind of help us in these situations. We're thinking about tools here, and I mentioned conflict and dealing with conflict. A lot of times people don't really get into the desk script in the TeamSTEPPS toolkits, but I really think that using this is a very good thing to do on a regular basis. We're talking here about kind of going at some misunderstandings, small mishaps, maybe protecting against that death by 1,000 cuts that could lead to a lack of resiliency on your team. So, you know, a good example for me of using the desk script, or a desk, where we add in that ask, is now a good time to talk, you know, kind of comes in this story about my kids. So the kids are going down the staircase into the basement using their sleeping bag as a toboggan. All right, so I'm going to ask, is now a good time to talk? And maybe as a parent I didn't ask so nicely. I'm sure it was, get over here. But, you know, in real world you'd ask, you know, is now a good time to have this conversation? In describing that specific situation, I was like, hey guys, I see you sliding down the staircase in your sleeping bag. I'm going to express that I think that that's a bad idea. You're probably going to end up cracking your head open. You can kind of tell a theme here with my kids of potential for bodily harm a lot. They're very rambunctious. I'm going to suggest other alternatives. Hey guys, it's winter out. We have nice sleds. We have hills by our house. You could fall in fluffy snow and not the hard basement floor. So why don't you go out and do that? And consequences should be stated. Well, you know, if you do hurt yourself, you're going to have to go to the hospital maybe and have stitches. No one likes stitches. Or another consequence could be that I'm going to ground you. So that's kind of a very simple way of using a desk script. But if we're using this and it becomes part of our standardized language and it's something there, the emotions removed, you could really nip in the bud any of the problems that might be building.
Yeah, Chris, I found that this is a very constructive way to offer feedback.
And I think a lot of people don't, it's one of the TeamSTEPPS tools that people don't focus in on a lot when they do learn about TeamSTEPPS, and I just want to put it forward as it's a good option. Another one that people don't talk about tons when they go through TeamSTEPPS is the I'm Safe checklist. This is all about self-care. This is about fostering resiliency by making sure that you yourself are okay. And so think about this not only, again, when you're dealing with something catastrophic, but it's just that checking in with yourself on an everyday basis. You know, Marcia, I know that the big thing with nurses is that people say they do like 10-hour shifts and they didn't eat and they didn't have time to go to the bathroom, and that's really going to hamper your ability to bounce back from something bad, right?
Oh, absolutely.
Finally, our last one is reluctance to simplify. Every system is complicated. Doesn't matter what industry you work in, there's always some complexities. And when we're talking about healthcare, we're talking about incredible complexities. And so it's important not just to simplify something just to make it easier. It doesn't mean you should back away from standardization, but it means that you need to make sure that when you're standardizing or when you're trying to make things more streamlined for people, you don't lose any of the really important areas just for the sake of brevity.
So when I was a nurse educator, I had the opportunity to work with staff on many problems. And, you know, one of the advantages of being the educator is that you hear how things are actually being done in the unit. We were actually, the risk manager really liked to talk to us because we learned a lot from the staff when we did some of our educational sessions. So the Quality Improvement Department in the hospital I was working on a CLABSI prevention project because they noted that there was an increase in CLABSIs in a particular intensive care unit. They determined that the cause of the CLABSIs were due to nursing staff not knowing how to perform a central line dressing change. So the education department, we set up a training session and all ICU staff were required to demonstrate a dressing change. So we obtained the dressing change kits from Central Supply, and during the training the staff stated that they'd never seen this particular kit. we talked to one or more nurses, and they all seemed to be surprised at the particular kit we were using. Well, we were a 2-campus facility that had merged 5 years earlier, and we're still in the process of standardizing our supplies. So what was happening is that the ICU nurses at one campus were still using the old dressing change kits that did not include a sticker to write the date for the next dressing change. So this really resulted in some inconsistent practices from the staff. We were able to alert the QI department and Central Supply about the problem, and it resolved rather quickly. So really, this is an example of being open to multiple reasons for infections. We also talked with the staff about, how they could add the dressing change information to their shift-to-shift handoffs. So again, to standardize the process with every single person every single time.
Thanks, Marcia. I think another interesting thing when we're talking about reluctance to simplify is we kind of ourselves in TeamSTEPPS sometimes are very guilty of utilizing something like SBAR for handoffs. And I think it's okay maybe to use SBAR for handoffs. So a lot of people do it. But what's not okay is when it gets put into somebody's EMR system, and in the process of that handoff, there's really no face-to-face discussion. And now you're just reading somebody's quick write-up in SBAR format. And a lot of complexities are lost. So, look at the difference between the TeamSTEPPS handoff tool, I pass the baton, or really any other handoff tool that's out there, and think there's probably a lot more nuance and complexities in here than there is just if you're giving somebody an SBAR to handoff when there's a critical moment when somebody's moving from a department to a department or maybe from one institution to another. So it's another one of those instances where we have to really be careful that we don't oversimplify. Okay, so we've bombed through the 5 principles of HROs, and we've also taken time to go through a bunch of TeamSTEPPS tools and try to make some connections. I feel that a lot of these tools would work in a lot of these other categories. They're all kinds of things that could support each other. So it's really thinking about how can you put this to work? How can you make this all happen? And so the first question I really always think of in these moments is how can we make this fail? So if we're talking here about, having that preoccupation with failure, if you were going to try to take a TeamSTEPPS tool or two and use it to hardwire some sort of value of a highly reliable organization into your institution, how could you make sure that it would not work? So we have a second here. I would love if some folks could just type in a few ways why they think they could totally make this fail in the chat area. And as people are thinking about this and things are coming in, I always go back to thinking about telling people, here's another big initiative. What is it that you are going to be telling people? How are you messaging it? How are you saying, guess what? Now not only are we doing TeamSTEPPS, but we're also going to be a highly reliable organization, and we're doing this and the kitchen sink and all of that. So I like the comments very similar. It's frame this as a project. It's something that you're working on it. There's actual steps to it. Implement without explaining why. Yeah, thank you for sure, Ellen. Good to hear from you. Yep. The comment about people who are not well trained in TeamSTEPPS, I think that that's very important for people to have a grounding in these tools, to not throw too much at them at one point. I do think that some of these tools don't need hours of introduction though either. I think that we very much can look at some of this and say, hey, I'm going to teach you right now what cuss is. We cuss on this unit. And that could be a quick 5-10 minute introduction of what it is to try to get people moving. Yeah, forcing change without explaining. That one just popped up. That is really huge, and that kind of ties into one way that I totally think that would make this fail, and that is asking people just to buy into something. So buy-in versus ownership is a big one for me, and this is how I like to think about it. So my wife is a photographer, went to school for it, very good at it, and always is trying to get pictures of the kids. So imagine what happens when you say to two kids, 8 and 10, and even before that, we're talking when they're little, 6 and 4, we're going to have pictures. We have to have pictures. And she gives all the really good reasons to why they should have their pictures taken. Grandma and Grandpa like to see you. We like to have a nice, it's nice to see what you look like every year. Oh, this is for the, holiday card. All of those things. Very good ideas. She's asking for their buy-in, though. And it'd be the same thing if you went back and said, we are doing this, and you're not explaining. You might even explain why it's important. You might even give some good data points, just like my wife might say, cuter holiday cards leads to more presents. All of this is very much, though, telling people what to do, telling people, you're going to do this, this is how you're going to do it, as opposed to ownership. So last year, we decided to take a different tack with my son at his birthday pictures. And we said, Max, you're going to have your pictures taken for your birthday. That is definitely going to happen. But it's up to you to figure out what you're going to wear and where we're going to do the pictures. So he picked out a cool outfit from his closet, and then he said, I want to take pictures on the train tracks. Well, even though we're preoccupied with failure, we followed through and we went to a little industrial area in our town. We actually found a hole in the fence and pulled it aside. Definitely looked like we were about to be graffiti artists or something. And we went in and we went up to the freight train kind of spur rail there, so it wasn't very dangerous. And he took pictures standing on the tracks with the cool old freight car that was beside. They were the best pictures that he'd ever taken, because we let him tell us how he was going to get there. And that's the same with this, where you have to provide people. You could say the end goal is to be an HRO. But if you provide people with these tools and say, here's a bunch of tools and how they kind of connect, that is now your job to figure out how to get there. If you say that to the people that you work with, they have that ownership and they have that ability to drive it forward. So that's just my little spiel on ownership and why it's important.
The example that I've used in healthcare is a renter versus an owner. So if you think about, when you rent a car, how do you treat it? But when you own something, you are invested in it. So that was just another way it kind of resonated with the staff when we talked about owning the process.
That's huge. Yeah, you don't change the oil or do a detail job on a rental car.
Correct. Yes.
So, we're getting towards the end here. I want to give a couple of minutes for questions, but this here is kind of a messy slide, but it's really just how we talked about things today. That the tools that are kind of matched up by color here, by order as well, I matched them up, and also by those arrows. So trying to look at it from as many different ways to help people see some of the connections. But as we kind of alluded to throughout, a lot of these are useful for other things. Briefs, huddles, and debriefs. We talked about it through the lens of preoccupation with failure, but that's sensitivity to operations too. That's understanding what people are doing. That's definitely a moment where you're going to defer to the expertise of the people in the briefing. It's a place where you can check for that resiliency and also check that things aren't being oversimplified and there's not that kind of moment. So all of these tools all kind of cascade on each other to get that shared mental model. And in the same way, all 5 principles of HROs are all incredibly interlocked and cascade on each other. So That's all we have. I know we only have 5 minutes, but Jen, are there any questions from the field?
Yes, and I'd like to say thank you to both you and Marcia. It was really nice and refreshing to hear relatable stories, clinically and non-clinically, and even outside of the office into personal lives. So I thought that was really great. So thank you. A question that we have is, so when you teach preoccupation with failure to staff, how do you help them kind of triage what they're focusing on? So how do you help them prioritize whether it's a really big thing that they're preoccupied with or one of those little nagging things that keeps bothering them? How do you tackle that?
Yeah, that's a good question. I mean, I think that you have to, you got to be looking at everything, of course. Obviously, if something is big, if there's a major potential error coming up, you want them to flag that right away. You want that to be their main focus. But when you're looking at it, you also don't want people to forget those nagging things, because those little things, either they should be trusting their intuition because those little things could turn into something big, or like we were talking about with resiliency, those little things add up and really end up costing you a lot of your ability to be resilient, because it's that death by 1,000 cuts. So I would say you have to look at both, but of course people should focus in on if there's a major error coming up.
And I agree. And with some of the what we might call seemingly little errors, put it back on the staff and say, hey, how would you deal with it? What do you think the solution would be? Do you have a suggestion? Because really you want it to be a two-way dialogue and not just the, continually tell me what's wrong. But really, how would you fix it? What do you think would help? That gets them involved, and it gets to that ownership piece as well.
Thanks, guys. I don't think we have any other questions left, but I would like to say just a few kind of logistical announcements. We are recording this webinar. Once it's posted on our website, we'll email everyone just to alert them that the recording is available. And then additionally, we just sent out the webinar feedback request, so we really do value your feedback on these webinars, so please, we'd appreciate that if you would fill that out for us. So Chris, any final words on your end?
No, nothing from me. Just, thank you so much for joining us today. This really is the start of a new journey with AHA team training, and we look forward to seeing you at trainings, on these webinars, at the conference, and making partnerships with us, because we're really dedicated here at the AHA to keep this movement going. There's so much continued potential here, and it's all because of all of you. This is an amazing group of people, and think about all of us as a giant team out there in the world who are doing this together. So thank you all for joining.
Ladies and gentlemen, that concludes today's presentation. You may disconnect your phone lines, log off your webinars, and thank you for joining us this afternoon.